Okay, good afternoon, everyone, or good morning. It's so nice to have you join us today. We're very, very excited to see so many of you interested in DULCE and this recent request for applications. I'm Patsy Hampton from the Center for the Study of Social Policy, and I'll be getting us started today. I think by now we are all experts at using Zoom, so I won't walk through the full etiquette, but I just wanted to let you know that everyone is automatically muted, and we are encouraging you during the time today to use a question and answer function. We've allowed some time at the end of the call to provide some time for questions and answers, but we also know that we have a lot of material to cover, and so we may not get that robust time that we want. So please ask questions throughout the hour, and we will answer those in real time. We will be sending out a recording of the call along with the PowerPoint slides to everyone who's registered for the webinar. And then in the next day or two, we will also send out the questions that were raised during the webinar today. So what we're going to do in this hour is have some brief introductions, and then we're going to introduce you to DULCE, talk about how it works, what the work looks like, what the evidence is, how implementation plays out, and then have some time to describe the request for applications. A little bit about CSSP. We're a national nonprofit organization that connects community action, public system reform, and policy change. We do that in order to achieve a racially, economically, and socially just society in which all children thrive. We do this through translating ideas into action, promoting public policies grounded in equity, supporting strong and inclusive communities, and advocating with and all children and their families, especially those marginalized by public policies and institutional practices. You're joined today by the National Center staff, the team at CSSP, in addition to myself. On the call today is Ozzy Armayas, who manages all of the DULCE work, all of that portfolio. Stephanie Doyle, who provides strategic guidance, technical assistance, and CQI advice to our team, and also Jang Lee, who supports our team through coordination, writing, and graphic design. We're also fortunate to be joined by the original co-developers of DULCE, Bob Sagi, a pediatrician at Tufts Medical Center in Boston, and Samantha Morton, CEO at MLPB. Bob and Samantha are going to be talking with you about what DULCE is, how it works, and the evidence that we're seeing through implementation. And I'm going to turn it over to you, Bob.
Sure. Thank you, Patsy, and thank you all for joining us for this RFA. This is a very exciting time for DULCE. In the next few minutes, I'm going to describe to you what DULCE is, but I want you to hold in mind sort of the kind of person who needs the services or uses the services that DULCE is designed about. This case from First 5 Los Angeles is a 23-year-old who came in a very arduous journey from Guatemala and ended up in California, where she was reunited with her husband and 3-year-old son. And if you think about all the challenges this person might face, you'll see why the support of a legal system, the early childhood system, as well as the healthcare system would be appropriate. And of course, think about her strength in making it here on that long journey. On the next slide, we'll talk about the components of DULCE, but first the name is Developmental Understanding and Legal Collaboration for Everyone. Developmental understanding because this is based on child and family development. We're very fortunate to have collaboration with the Brazelton Touchpoint Center to develop a relational approach to child development. Legal collaboration, you'll be hearing more about this, but in order to help families with the concrete supports they need and are entitled to, the opportunity to have a legal partner involved is important. And finally, within each clinic in these low resource neighborhoods, everyone gets DULCE. The only risk factor that matters in this case is having a baby. So if you look at the next slide, you see how we think about the three systems that are involved. We want to improve the health and well-being by transforming the way that families experience the delivery of supports and services beginning as soon as their children are born. So what DULCE does at its basis is we get support from legal and early childhood system, and we add that in to routine infant health care. And the reason for that we'll go into more detail, is so many families get that routine health care. The next slide discusses what exactly the intervention is. For the first 4 months, there's a mixture of screening for things like maternal depression and concrete supports, as well as parent coaching based on the relationship coaching from touch points. The 6-month visit, which is when the DULCE intervention formally ends, is a wrap-up intervention and a transition, so the family-centered medical home can continue the care. In order to make this work, there's a weekly interdisciplinary case review, which assures that all positive screens are addressed, and there's an opportunity for collaborative problem solving. Legal partners are involved throughout, both in designing how the family specialist can respond to needs and in collaborative problem solving. And as opposed to other programs that rigidly replicate one model, we use a quality improvement approach so that we can respond to the needs of the families in those communities.
Thanks, Bob. This is Samantha Morton, and I'm delighted to shift from conversation about components and intervention to what DULCE's magic is, which is really alignment and integration. When we think about the practice level elements of DULCE, when we think about how these sectors that have long sought to operate outside of silos come together through DULCE, the first is through teamwork and a new kind of team, a stronger team, where a family specialist, a community health worker equivalent, is integrated officially into the primary care team. As Bob said, there is universal access to DULCE services and support during a child's first 6 months of life. And of course, we're going to talk later about DULCE's flexibility beyond that window of time. Families are in charge of what they want and receive, and how they can engage with DULCE support, and importantly for integration and alignment, and what we like to call in DULCE silo busting. The 3 sectors come together weekly for an interdisciplinary case review that allows for smart family-centered care planning and support. At the community level, the early childhood system lead is a pivotal anchor to making sure that the DULCE team is serving families in a way that fully harvests all available resources and services with which early childhood systems are so familiar, and make sure in very concrete ways that the strengths of the 3 sectors are fully optimized for DULCE families. Next slide. So why these 3 sectors? These 3 sectors are critical to DULCE, starting at the left, because early childhood systems are fundamentally and uniquely accountable for system building that brings a population and population health and wellness lens to the needs and goals of families with young children. Early childhood stakeholders are immersed in the landscape of community supports and immersed in, frankly, the gaps in those supports. They are drivers of evidence-informed practices and programs, and they are organized to catalyze change at policy and practice levels. Health systems, child health care practices, like pediatrics practices, have this wonderful universal orientation. They have continuous longitudinal relationships with families, especially through well-child visit schedules and standards, and they are adept in quality of care mechanisms as ways to effect family-centered changes at systems levels. Finally, the legal community with which my heart is tied in particular is very fluent in families' legal rights, risks, and responsibilities, as well as system and institutional rights and responsibilities. They are professional problem solvers, and they bring important lenses on how change can be accomplished and how rights can be vindicated at household, system, and policy levels. Next slide. And this is back to Bob.
Great. So I want to just tell you that there is a lot of evidence for DULCE. It started almost 10 years ago at Boston Medical Center, and we published the results of a randomized control trial where half of the patients received DULCE and the other half received sort of a standard patient-centered medical home approach. What we found was the families who received DULCE used the emergency department less, and this only makes sense if you understand that many parents who, of course, are concerned about their baby bring the baby in for things like they won't stop crying or they're not acting right, all kinds of things that can be helped by better access to developmental support. Better adherence with well-child visits and immunizations. We substantially improved the clinic's ability to deliver on-time immunizations to our patients. Greater access to concrete support, including food support like SNAP, utility services, which is obviously incredibly important in winter in New England, and a number of other services. So overall, we found that their access to concrete support was sped up by about 6 months compared to the remainder of the clinic. At the practice level, what we've now found in the current implementation of DULCE is that more than 3/4 of our families receive all well-child visits on time for the first 6 months of life. We've been able to help clinics successfully implement the new Bright Futures guidelines, which includes indications that the healthcare system needs to be looking at health-related social needs. DULCE clinics report having lower no-show rates than non-DULCE clinics, and as a former clinic administrator, this is a huge advantage because when someone doesn't show up, there's a doctor and staff or a nurse practitioner available who aren't available for other families. And physicians and staff credit DULCE with improving the work environment and reducing burnout. As one of the doctors at our clinic said, "This is why I became a pediatrician, to address the things that really matter for families and children. Through DULCE, I can." Next slide. The most important thing, though, is that DULCE is successful because families love it. Almost all families accept it. Almost all families complete the intervention. The 83% go through all 6 months. Most of the ones who don't are because they move or they change their service to another clinic. And this compares favorably with other programs that are aimed at reaching some families. And here's what they say: "My confidence as a mom has improved, which helps me express our needs as a family better. And I understand changes in my child and how to address them. I know when I'm getting overwhelmed and need a break, and always make time to relax." Next slide. More quantitatively, at the practice level, 85% of the mothers were screened for maternal depression, 18% screened positive, and of those, 90% received information about available supports, and really amazingly in this whole field, 78% of the families did access support for maternal depression. 83% of moms were screened for intimate partner violence, 3.5% screened positive, 84% got information, and of those, 2/3 accessed supports. Again, this is a testament to the relationship-based practice that DULCE has between the parents and the family specialists. Next slide.
And this is Samantha Morton again. Thanks again, Bob. Just continuing to describe what we've learned about impact for DULCE families. DULCE, by bringing together and again aligning early childhood, legal, and pediatrics perspectives, makes possible a kind of family-centeredness when it comes to social needs screening that I think has been elusive, even in a time of tremendous national energy around standardized social needs screening within traditional healthcare settings or more familiar healthcare settings that are not as integrative. And we are thrilled to see the levels of families who are fully screened for 7, count them 7, health-related social needs delineated here on the slide. And the ability of DULCE teams to connect families with critical information about resources that are available to them in a range of domains of material hardship. And as you can see from the statistics noted here, families are being equipped minimally. And I know we'll talk in a few moments about how we transcend this kind of resource information conveyance, but minimally, families at very high rates are receiving valuable information that help them make informed decisions about access to housing, access to nutritious food, economic stability, and resources that can support, that can promote behavioral health and maternal depression. Next slide. On the subject of how DULCE, particularly through the integration of legal partners, can help build on the strength and the power of equipping families with accurate information about resources available to them, we know from 5 years of wonderful experimentation and refinement of DULCE in 5 counties in California, Florida, and Vermont, that by integrating legal partners into DULCE case review teams and meetings, there are impacts both at the household level, at the family level, and also impacts in terms of what DULCE teams, family specialists, and then clinics and communities can start to do as standard of care for other families who present with similar circumstances. And in this example here, because a legal partner was present at a case review, they were able to identify that a particular family might be eligible for naturalization or citizenship, which is an extremely valuable status to achieve if one is eligible in our country right now, and it always has been. And not only did this lead this particular family down a path of learning what they could possibly do with support from an immigration expert, but it also teed the family specialist up to be looking for families in similar circumstances so that they could present to those similarly situated families information about their potential rights and remedies in the future. And that really is a system change and system strengthening practice. Next slide. Taking us from the household and system level to the policy level in terms of DULCE's impact and potential impacts in your communities, legal partners in Los Angeles and in Alameda County in California were able to spot through DULCE case review meetings with early childhood and especially clinic partners that Medicaid coverage of transportation benefits and also Medicaid barriers to Medicaid enrollment, continuity of Medicaid enrollment of newborns, and sometimes their moms, were disrupted in ways that were frankly illegal, regardless of whether it was intentional or accidental. That doesn't change the illegality. And this triggered and has continued to trigger for participating DULCE legal partners a commitment to systems and policy level advocacy with those institutions that have this power over families' lives. Next slide. So DULCE implementation, what does this look like? What could this look like? And you know, my privilege right now, as I get ready to pass the baton to my valued colleague Patsy Hampton from CSSP in a moment, is just to really frame for all of you who have expressed interest in learning more about this RFA and really learning more about taking charge of pioneering an integrative approach in your community. You know, my pleasure and my privilege is to say to you here that this is an opportunity to be part of moving from theory to practice in our country and our culture right now. There is a lot of conversation around social determinants of health. There's a lot of invoking of early life stress and ACEs, adverse childhood experiences. There's a lot of recognition, and frankly, over the last few months, renewed or sort of surprisingly explicit recognition in relation to historical precedent of structural racism in our society. And where the barrier often lies is in moving from recognition and acknowledgement to action and to new kinds of partnerships that look outside existing walls and existing comfort zones. And what DULCE offers is a blueprint for doing that with not 2, but 3 sectors who all share a mutual goal and, frankly, mutual constituency, which is families with young children. And so we really are excited to get to know you through this process and are excited to welcome some of you into the DULCE National Network, which is in the process of transforming child health care. Next slide, and I'm passing this off to Patsy.
Thanks, Samantha. Thanks, Bob. We are really excited about this opportunity because we're interested in DULCE expansion in other parts of the country. So we are currently in 3 states, Vermont, where there are 5 sites. In California, we're in Los Angeles, Orange, and Alameda County, where there are 7 clinic sites. And then in Palm Beach County, Florida, where there are 1 site. So 3 states, a state that's really rapidly moving to become more statewide, and then in California and Florida. And so as we pursue this, there's a growth of DULCE, we're very interested in learning what it looks like with other geographies and other populations. I'm going to spend a little bit of time walking through sort of the major milestones of what DULCE implementation looks like. We've mapped this onto a framework developed by the National Implementation Research Network, NIRN, the stages of implementation, to sort of help shape the planning for successful implementation. And this is based on our experience of onboarding the now 13 communities that we have that are implementing DULCE. So in the beginning, folks started this exploration stage, and that's designed, and that's a stage where I think potentially many of you are. That's why you're interested in this RFA, and that's why you're on this webinar. It's really designed to further assess community needs, to better understand what DULCE looks like, what the implementation components are, and to get stakeholder buy-in. And in this phase of exploration, what you're doing is you're doing things like figuring out who's the lead, where are the likely clinic and legal partner organizations that you think can make the most difference in this work. How do you engage family voice and family participation in bringing something new to your community, to bring this new sort of way of thinking about child health transformation. That all leads to the work of developing a work plan to support installation and implementation. This process typically can take about 3 months. The RFA application itself is designed to take you through some of these initial steps, thinking about a lead organization, clinic partners, legal partners, ultimately preparing you for the funded opportunity to develop an action plan for implementation. The installation phase, which is designed to put in place the resources to prepare the organization and the staff for implementation. This phase can typically take about 6 months, and that involves identifying staff, building the team, developing your onboarding process that will help support you to do. We at CSSP and our national team, you'll be doing things like testing what screening looks like and what support's needed to do that, what it looks like for the DULCE family specialist to be in the clinic, sort of testing out clinic flow. And doing that ultimately by beginning to see just a few patients to sort of see what it looks like and adapting the work to your community needs. This RFA is really designed for folks who are in this exploration installation place. Some of you may just want to sort of dig deeper into what DULCE looks like within your community. How do you bring the stakeholders together? Others of you may have had opportunities to think about DULCE in the past, or have some immediate opportunities, ideas about how you can sort of jumpstart this process. That would put you more in the installation phase. It's for folks in either of those categories, organizations in either of those categories. Following that 9 month sort of exploration and installation phase, which can sometimes take a little bit longer, we move into this initial implementation. And that's where that phase is really designed to adjust and adapt. It's sort of to get started and to get better. So we implement continuous quality improvement. It's a place where you develop new solutions to barriers or obstacles that are getting in the way, or challenges that you may be facing. It's also a time for you to deepen your ability to engage families in feedback about how the intervention is working, how the approach is working, what would they like to see differently. It's a way to deepen your cross-sector team meetings. You'll hear from us a lot that these cross-sector, the interdisciplinary of DULCE is really the secret sauce of DULCE, and folks find that the deeper they get into the work, the more and more they value their colleagues in this cross-sector partnership. It's also a place, this time around initial implementations, where you really begin to identify the practice level changes and the system level changes that Samantha alluded to. And it's a place where you can really strategize a little bit more about long-term funding. Full implementation is where DULCE becomes part of the culture. It's just what you do, it's business as usual. You use, and during full implementation is the phase of time where you're really using CQI to adapt the processes, to sort of better the work, refine it. You're using the data that's generated to build your evidence base locally, better making the case for DULCE, and better making the case for the system changes that you're seeing impacting the families that you're serving, using data to do that and using your cross-sector partners to do that. It's also a phase where people really begin to understand and think about how you spread DULCE to other clinics and other locations across your geography. We lay this out to emphasize the fact that we see the implementation of DULCE as a process that happens over time. You're fine-tuning and adapting as you go, and the technical assistance and support that you'll get from CSSB is designed for each of these phases to help support your success in the implementation and adaptations over time. A little bit about the cost of DULCE, and it ranges a bit in part by geography and locality. What I've listed here, what we're showing here, is budgets across our current sites. And these are from sites that are fairly well established. And as you grow the work, as you bring on new clinics and new family specialists and more legal partners to go beyond a one clinic, the cost will increase. The biggest expense in DULCE is the salary for the full-time family specialist, and the family specialists are typically community health workers. That is the workforce that we draw on for this particular approach. They are folks who are of the community. They know the families well and have their feet both in the health sector and the community sector, and are the liaison to get families connected to the services that they need in a quick way. The other sort of larger expense is the equivalent of a 20% of an FTE junior attorney representing a legal partnering organization. That is the legal partner who provides, or partners who provide support to the team and to the family specialist around the concrete supports. Again, the costs vary. They're driven by local salary and benefit costs, by just variations in your approach to family leadership and engagement. Some communities sort of budget a larger line item to have families more fully engaged in feedback opportunities. And there are also costs incurred by, there are existing positions that are used, and there are some small percentages of time to cover a medical champion, who is the person at the clinic who really is the cheerleader for DULCE at the clinic site, a mental health representative who provides clinical supervision and reflection to the family specialist, and also a project lead to sort of put the pieces together and manage the work. The funding for DULCE comes from a variety of sectors, and it looks different in different places across our sites. All of our sites now are deep into sustainability plans, and they're finding resources from their existing early childhood systems, from local foundations, from managed care organizations. They're looking at federal Medicaid policy opportunities, as well as looking at hospital benefit systems, United Way, using pro bono legal support in some cases to support the legal partnering work, and also thinking about the various healthcare associations that are in place in many communities and in many states. In the slide that you will get after the webinar, there are 3 slides that we don't have time to go into detail on this call, but that outline the Medicaid levers that can cover the cost of DULCE depending on your state's Medicaid plan. There's also a slide that outlines the value of DULCE to managed care organizations who really are very much looking at cost savings as well as practice transformation. And then there is another a slide that sort of maps out how DULCE is a tool to accelerate practice transformation. So those slides will be available to you after this call. I want to walk through the RFA opportunity for a minute and just reinforce that the purpose of this RFA is to accelerate local planning toward implementation. We know that everyone's plates are very full, and we recognize that if you want to do something and you want to begin to plan for something, to do something different, you need the time and the space and the capacity to devote to that effort. And these funds are really designed to help offset the staff time that it might take to support the planning needed to get this up and running. The result of this RFA is that you will either find yourself with a solid action plan for getting started, or you'll find that during that 9-month process, you will be able to get started and actually begin to see families. We are awarding 4 planning grants for up to $40,000 each. And these can be used in 2 different ways, as we've said. One's to develop an action plan with the idea of implementing DULCE within the 9-month period. And then the other is to augment some existing funding to begin implementation in the hopes that you begin to do that within 6 months of the 9-month period. In addition, we are interested in communities that are interested in adapting DULCE. So as we've worked with these 13 clinics across the country, we're hearing some folks say things like, DULCE is great, we love it, and I really wish we could have reached families earlier. And we've talked to some communities who are interested in looking at what DULCE looks like prenatally, what it would look like, for instance, if you mapped on some of what we do to a doula program or to some other prenatal approach. We've also had clinics say, given that we've had so much success in the 6-month visit, it feels short and we'd like to go longer. So can we go to the 6 months, extend it to 9 months or 12 months? And we're saying, yes, you can do that. We've also had folks say, this would look really interesting in another health-related setting, such as a WIC clinic. And can we, what would it look like to do DULCE in a WIC clinic? And so this is a chance for us to learn from you about what some of these local adaptations look like. So we're interested in communities that are interested in doing DULCE as it's currently being implemented, from the first newborn visit to the 6-month visit. And then we're also folks interested in hearing from folks who are interested in doing something a little bit different. In terms of the applicant responsibilities, the opportunities in this grant are to designate a project lead, to identify your sector representatives, the early childhood system, the health representative, and the legal sector representatives, to use this time to build a team, to define the team roles and responsibilities, to develop an action plan, to develop partnerships for funding, to monitor progress towards your goals, participate in learning opportunities. We will at CSSP be offering up regular technical assistance calls to the cohort of communities that are selected, and we'll be also providing one-on-one coaching calls. We'll also provide resources to you through using our DULCE learning portal, and also connecting you with folks who are doing DULCE now. There'll be many learning opportunities for you. And then we ask that you, just inform of any change along the way. These we wanted to share with you as being some of the criteria of things that we're looking for in terms of selecting the recipients of these awards. As I said earlier, we're really looking at diversifying our demographics and geography, so we'll be looking at that. We're really wanting to understand what you're seeing as the need that DULCE is filling. What is the landscape within your early childhood system, and what is the gap that you're seeing DULCE being able to address in your particular context? What is the capacity of the lead organization in terms of bringing stakeholders together, being able to engage with others, sort of helping shape the implementation of something new and different, and making sure that stakeholders are brought in all along the way, developing those and cultivating those partnerships along the way will be something that we'll be looking for. If there are partnerships that you don't already have in place in the RFA, in the application, we're interested in understanding what kinds of things you might be doing, you might want to do to build those partnerships, or what you might need from us in terms of technical assistance to solidify those partnerships. We're also going to be looking at this from an eye of equity and parent voice. DULCE as a universal approach is offered to every newborn who is engaged in a clinic. We typically focus on clinics who see high numbers of families who are living in poverty, who are eligible for Medicaid, and who are disenfranchised because of race and income. We're wanting to see how you'll think about engaging families in the design and implementation. That's something that our current sites have been working on as well, and we really feel like this is an opportunity for us to go deeper into really bringing in families of very young children into help shaping the set of opportunities that will be available to them. Also, as we think about what we're selecting in the criteria for the selection, we'll be looking at what kinds of financing and sustainability opportunities you're aware of, what kinds of things you're interested in pursuing, and just get a temperature of what that might look like within your community. We know that that's going to be a question for all of you, and so we don't expect for everyone to have a solid funder in place where you begin this work, but we are interested in really learning about how you're thinking about exploring this, who those partners are, and what those opportunities might be. In terms of dates, the application is due on the 21st of August. We see that we'll probably do interviews with a set of finalists, and then we'll make the awards, and we'll announce the awards no later than the 25th. And again, it's for a 9-month funding cycle. The application itself, because we know the additional pressures the pandemic has brought to systems and to our organizations, especially many of you who are either at state organizations and local organizations. We know that in many ways you are first responders and supporting families during the pandemic. So we wanted this opportunity to be as easy of a lift as possible. So we've developed what we hope is a short, easy application form. It's in SurveyMonkey. We have, I think it's 8 narrative questions. We've limited the length of the questions to between 300 and 500 words each. So we do think that it's something that won't take you very much time to put together once you've had some conversations across your community. So I think we'll stop there. It looks like we're better on time than we thought. See how we might open this up to others. I'm wondering, I haven't been able to look at the questions, Bob or Samantha. I'm wondering if you want to start with that, with raising up a question.
Sure, Patsy, someone asked whether family specialists are a required component. Their clinic has other resources available.
That's a great question. And Bob, maybe we can piggyback on that. So my response is that the work of a family specialist is a full-time position. It though can be shared across positions, as long as, like we've always wondered, what would it look like if an existing staff person learned the role of the family specialist and served that functionality. So I think that that's how I would start to answer it. And then Bob, I'll pivot to you, because you and I have had this conversation a bit. So love to hear your continuation of that answer.
Yeah, I think that the key to DULCE in many ways is the family specialist and the relationship, because they're present at all the routine visits and form a relationship with the family. They're often able to identify needs that otherwise aren't clear through existing screens or other ways. So we found the family specialists are kind of a linchpin. And I just want to add that to what Patsy said, in that many clinics hire existing staff who have some of these relationships to form this job.
Hi, everyone. This is Samantha, and I am seeing some exciting and interesting questions about legal partnering. And Patsy, please stop me if I should pivot to a different question.
No.
But I just wanted to weigh in on Heather's good question about the legal partnering and whether it's through a legal aid organization. So this is where, while legal community resources are limited in all communities in the country, I don't want to beat around the bush on that. Every community thinking about participating in DULCE has a critical opportunity to really get to know its public interest law resources. And while the most familiar public interest law resources to most people are legal aid organizations, those that operate in every county in this country and are able to meet the needs of roughly 10 to 20% of the people who are eligible for their services. And they do amazing yeoman's work, serving multiple populations across multiple domains of civil legal need, like housing and public benefits and bankruptcy and other things, very, sort of organization dependent. One encouragement that we have for communities interested in DULCE is to really think about the families they wish to serve through a pilot, and whether there is data, which I suspect there is, on what dominant legal needs may be impacting those families. So, for example, if a community is interested in making sure that families with immigration law related needs have their needs met, there's actually a lot of restrictions on legal aid organizations around who they can serve and in what ways. And so I just want to encourage you, recognizing that legal community resources are limited. There is a kind of process that we, CSSP and the DULCE national team can support to help you with asset mapping. For example, many communities have nonprofit law organizations that are focused specifically on the legal rights of children. And that might be an interesting place to start a conversation around DULCE partnering. So I just want to really reinforce that the floor of DULCE legal partnering is support for the team, support for the DULCE team from a public interest law partner, and another component that is often something to be built toward is legal partnering that actually offers direct, free, high-quality legal assistance to families. Those are two different kinds of functions, and there are two different kinds of expertises. Just to build on this, and then I'm going to be quiet because I know there's so many other important questions. I see a question from someone who's part of a medical legal partnership law school clinic, and Is a law school clinical program a sufficient legal partner? The short answer, it depends. Again, from an equity lens, from a family-centered lens, starting with documented family needs in your community is something we're going to be looking closely at, as opposed to starting with, hey, here's the legal resource that exists and might be interested, if that makes sense. I don't mean to be discouraging. Your interest is amazing, and I think it would be so exciting for a law school-based MLP to be involved. Typically in our experience, law school-based clinics are focused on getting their students case handling opportunities, and that's wonderful. But that is a part of the DULCE legal partnering puzzle. That is not the foundation. So would be very happy to talk more about that outside the context of this Zoom. Let me pass it back, Patsy, in case you want to direct us panelists to answer other questions.
Yeah, I'm seeing a question from Beth that Bob, excuse me, that Bob was going to answer around the health clinic taking the lead.
There were several questions about health clinics, so I just want to answer them together. So the health clinics need to be involved, but what we found at our existing sites is that when an early childhood partner takes the lead, they're able to look at implementation in multiple clinics, which has obvious advantages. So you'll see in the RFA that the suggestion is that the early childhood system, whatever that is in your area, does take the lead with obviously the active involvement of the clinic. And then the other two questions that deal with the clinic is, one person asked, how do you investigate sharing the family specialist in a busy clinic? And I just want to clarify that all the members of the cross-sector team are not present in every visit. What we have is the family specialist joins the families of newborns for their routine visits through the 6 months of life, and there are up to 5 scheduled routine visits during that period. But the cross-sector team participates in a weekly 1-hour case conference. So typically it would be the family specialist, the physician and nurse practitioner, and the family in the room during the visit. And the family specialist would carry on the connection with the family in between visits. Some clinics that are very large can't have the family specialist see every baby. So they've adopted a system where babies, for example, who are born on even numbered days are eligible for DULCE, and those born on odd numbered days are not. In general, the clinic can sort this out, but it's really important to specify that not everyone is there at all times for all families. And I think that what you'll find is that because families show up at the clinic, they're continually, the other thing that DULCE can do is form a link between the health system and other community partners. So we've seen that as DULCE develops through the early childhood lead agency, often other projects or interventions for other individual families are facilitated through this in-person connection.
That's great, Bob. Thank you. I'm seeing a question here, and I think I saw a couple of questions about can DULCE, basically, the connection between DULCE and home visiting. And I just want to, and it may have been answered in writing, but I just wanted to say that what we've seen with our current communities is that DULCE can accelerate connections to other programs. So in one of our sites, they have a maternal home visiting program that starts at the birth of the baby. They do some screening in the hospital, and then they offer a home visit. In the hospital, the family may say, yes, I'd like a home visit. But when the home visitor calls the family is is a little bit more reluctant to take them up on the home visit. What they're finding is that through DULCE, because the families are going to the well child visit, that what we know about families is regardless of regardless of their situation, as you saw from some of the data earlier on, they're going to go for those well child visits for their newborn. And so the DULCE family specialist is able then to introduce them to the home visiting program or to that resource, making a warm referral. The family specialist still connects with the family and supports their other needs, but they're able to accelerate the connections to other services and supports that will be longer in duration than the 6 months. That's one of the beauties of DULCE, is it's an accelerant to connecting families to services. The other thing that we've seen with DULCE in another site regarding home visitors is that the DULCE family specialist might do a joint home visit for the first time the family is being introduced to the home visitor. So they do it together, so it's a partnership. One of the amazing things about DULCE is that the family specialists are just, and I say this, we have 13 in very different places. They are gifted in developing really fast, deep relationships with families, gaining their trust, understanding what their needs are, and really supporting families in ways that connect families more quickly to services that they can benefit from. And that's one of, I think, the most powerful testaments that we have of the work. Let me see if there are any other questions.
I'll just add one other thing to that. I think that one of the things that home visiting does successfully is provide parent coaching and that early relational health component, and DULCE does that too. And that's in addition to the screening, because it's very easy to quantify the screening, but it's a key component. And I love the questions, and people are looking at how this relates to home visiting. One person early on commented that DULCE is like home visiting in the medical home. And sometimes that's sort of helpful to think about it that way.
Right. Somebody asked if we could talk about the qualifications of a family specialist. As I said, we consider them to be community health workers. They are people who understand the community very well. They are of the community. They look like the families that are being served by the clinic. They are people who we don't require degrees. They don't have to have a child development degree or a bachelor's degree or a master's. They are people who we expect would have some knowledge of child development and infant development. We do training ourselves around that. We expect that there are people who know community resources very well, and we expect that there are people who are very interested in, they're people who are able to get to know families, to listen to families, and there are people who are also very well networked within the community to really understand where the resources are. We too, in this work, we have a list of what we consider to be the qualifications of a family specialist that we could send out. And I'm looking lastly, in the last couple of minutes, we have a question about whether if we offer DULCE prenatally through 12 months, would we need to partner with a prenatal clinic and a medical clinic? We would want you to partner with a health clinic. So, in some places that could be an all-in-one place, but it would need to be in a health setting. We would want the health partners to be part of that work. And that's the prenatal space is an area that we're growing into, and would be very interested in learning how to better support that. And it looks like, anybody else have anything else to say about that question? Okay. We will, in the slides that we send out, we will send you our contact information. Feel free to call us to just talk about any of this. We love this work and love to talk to people who are interested in doing this, and happy just to answer any questions that you might have, or any follow-up questions that may occur to you after the call. I think our email, the main email, is on the RFA itself, and then we will be sure to send you the information of the presenters as well. Any other questions that I'm not looking at, Jane or Bob or Samantha? think we're good. Thank you all so much.
Thank you.
Thank
Thank you very much.
Thank you. Bye-bye.
Bye, everyone.
Bye-bye.